speaking our program. I'll hand it off to Dr. Balaji and Charlie.
All right. Thank you very much for that introduction and welcome everybody to this conversation. Charlie and I will be speaking about myths related to strength training in young athletes as well as injury prevention. Next slide. So our objectives are to initially I'll spend some time quantifying the problem of injury prevention in pediatric athletes, and I'll use an anatomy-driven approach to provide a solution to how we may be going about addressing injury prevention. And then I'll hand it over to Charlie, and he'll review some evidence-based myth busting of youth strength training and correlate that with safe youth strengthening protocols. Next slide. So to start us off, I'll begin with a couple of quotes that I think are important for us to keep in mind. Both of these separate quotes are somewhat related and were driven into me during my training process. So it's important to consider that pediatric patients and children are not just little adults. They can be a medically vulnerable population with unique anatomic, physiologic, and psychosocial traits that should be carefully and individually evaluated and addressed in a holistic and conscientious manner. Next slide. And kids, when left to their own devices, generally don't get tendinitis because they have the good sense to stop when things are hurting or bothering them. And it's only when adults get in the way that problems arise. And we'll use that to speak about the next several slides. So let's talk about the good. So in the United States, up to about 60 million young children are participating in organized sports. And there's obviously many positives associated with sports participation as young children. It can be a very healthy part of normal development. It can lead to advantages in terms of physical health compared to their sedentary counterparts. And it can also improve social communication among teammates, classmates, and even opponents. And it can also have some mental boosts as well. About 8 million of those children are involved at the high school level, and particularly with youth soccer, there's been a 90% increase in participation from an organized standpoint in the United States between 1990 to 2014. So let's talk about some of the bad. About 50% of all pediatric injuries that go to the emergency room or the emergency department are due to overuse injuries related to sports and are very preventable. And there's been a 111% increase, or basically a doubling in ED visits for specifically soccer-related athletes. So just as the volume of soccer athletes has increased considerably from 1990 to 2014, there's been an almost disproportionate increase in the injuries related to ED visits in that same population in that same time frame. Next slide. So let's talk about, well, what gets hurt? We'll do a quick anatomy lesson, not going into too much specifics, but we know generally speaking, when it comes to the musculoskeletal system, we're speaking about the health of muscles themselves, the health of the tendons, which attach the muscles to bones, the health of the bones themselves, and then the health of the ligaments, which attach bones to other bones. So one thing that, as I mentioned in the beginning with the two quotes, one thing unique about pediatric patients is the presence of growth plates or areas of rapid growth. There are different types of growth plates. There's, of course, what we call the physis, which are found along long bones and are responsible for longitudinal growth. But there's also other types of growth plates called apophyses, which are secondary centers of growth that are associated with attachment of important tendons along the musculoskeletal complex. So these areas of growth, these apophyses, can become overused when children are particularly very active during periods of rapid growth. And there are numerous apophyses located throughout the body, but perhaps the most important ones associated with injury prevention are found in the foot and the ankle, the knee, and the hip and the pelvis. Next slide. So what can we do about it? Well, let's talk about what we usually end up seeing first. So there is important considerations to have when we're talking about how do we prevent an acute injury versus an overuse injury. So acute injuries, as the name suggests, are injuries that happen from a one-time event that leads to some significant strain, sprain, or fracture. So sprains are the general medical term we use when we discuss, injuries to the ligament. A strain is the specific injury pattern we discuss when we're talking about injuries to muscles or tendons. And a fracture, of course, is an injury to bone itself. Now, that's to be contrasted with overuse injuries, which are not really associated with a one-time event, but rather cumulative microtrauma that over time leads to swelling, pain, irritation, or inflammation in various areas. So if it's going to be at the tendon, we will consider that to be tendinitis. If it's going to be at one of these secondary growth centers, the apophysis, then we'd consider that apophysitis. And if it's an overuse bone injury, then we can consider that a bone stress injury or potentially a stress fracture. Next slide. So here is a typical story I might hear in a young athlete who's coming to see me for an acute injury. They may say something along the lines of, I was running or sprinting or changing direction, and I felt a sudden pop or pull or burning pain, and I couldn't continue. And one thing they might add on is that, now that I think about it, in this same area that I'm coming in to see you, I was actually feeling a little sore and tight in that area for the last week, but I just thought I needed to stretch through it and keep going. So this is a pretty typical story we generally hear when we're talking about a patient who may have suffered an acute injury to a muscle or tendon, which we call a strain. Now there's a pictograms throughout the bottom of this slide indicating MRI T2 weighted signals that show increased uptake in areas of muscle within the lower extremity, particularly the calf and the gastroc muscle. And you can see as these arrows point throughout these panels that the brightness indicates that there's edema or increased fluid accumulation associated with where these muscles and tendons are, indicating that there's been an acute strain or tear in this specific area. Next slide. Now, there are many, of course, there's numerous muscles throughout the lower extremity. Typically in sports, particularly in cutting, pivoting sports, the muscles that we worry most about becoming injured are the quadriceps, the hamstrings, and the calf muscles. Now, the hamstring muscles, which are obviously located on the posterior aspect of the thigh, stretch from the pelvis down into the lower part of the knee. And there are some specific protocols where utilizing the body weight leverage to specifically strengthen and train this muscle can decrease the risk of injuring these muscles in the context of training as well as the context of competition. This pictogram in the middle shows a gentleman who's doing what we call a Nordic curl, where his lower extremities at the ankles are tied in and leveraged, and his body weight is leaning forward. The purpose of which is to elongate the hamstring muscles under tension. This specific type of movement is called an eccentric load of the hamstring muscle. Next slide. This is a really incredibly effective form of strengthening hamstrings during the process of training to prevent injury. Numerous studies have been performed regarding this specific type of strengthening protocol, but one that was recently published among soccer players indicated that injury prevention programs that included the Nordic hamstring curl exercises decreased the risk of hamstring injuries among soccer players. So not only is this specific exercise useful to rehab from a hamstring strain, but it also is very effective before a hamstring strain occurs in the first place to prevent them from happening in the context of sport. Next slide. Of course, almost everybody who is paying attention and listening today is probably aware of the typical presentation of ankle sprains. We generally think of these as an inversion injury to the ankle where the ankle rolls laterally and the three important ligamentous complex on the outside of the aspect of the ankle or the lateral aspect of the ankle become sprained. As they are ligaments, they would become sprained. The typical clinical presentation of ankle sprains is swelling, difficulty walking comfortably, bruising, especially dependent bruising, as you can see in that top right photograph, where the swelling and irritation and ecchymosis leads to pooling of the blood towards the bottom part of the ankle due to gravity. Now, ankle sprains are very common throughout many sports, and the typical treatment for them is early utilization of rehab protocols to strengthen the ankle and get it back to early motion. That seems to improve outcomes and get patients back to sport faster than immobilization alone. A safe way of utilizing protection while allowing for early motion is the use of a lace-up ankle brace that's diagrammed on the bottom left panel. And on the bottom right panel is an example of a type of what we call proprioceptive exercise, which is to say, trying to get that injured ankle to fire in a manner that provides balance. And that is an incredibly important process to focus on during the injury prevention protocol. Next slide. The reason that we're spending some time talking about proprioception is that this specific type of training where single leg balance is utilized to improve the balance of the ankle and improve motion and strength of the ankle, that specific mode of training is very effective in reducing the incidence rates of ankle sprains in the athletic population, including those who have already had one in the past. So this is an important training protocol that helps patients who have had ankle sprains rehabilitate successfully back from that injury. But even if you've never had one, it's effective in preventing ankle sprains in the context of training and competition. Next slide. So this is an example of a couple of soccer athletes who are in maximal hip external rotation and extension before they're about to strike a ball. This is a common position that numerous soccer athletes throughout various ages find themselves in. And in the young pediatric population, it's important to consider that they find themselves in this position frequently because it puts a lot of muscles that attach to the pelvis and hip and the associated growth centers in those regions at incredible amounts of tension. Next slide. So the reason that this is important to consider is that in the developing patient, in the developing pediatric patient with open growth plates, there are numerous apophyses across the pelvis through which various very strong tendons insert. And that X-ray in the top left demonstrates what we call an avulsion of one of those areas, the anterior superior iliac spine. As you can see where the arrow is, there's a little bit of an ossific density in that location compared to the contralateral side. That ossific density that seems to be displaced from the native aspect of the pelvis itself indicates that that area has been pulled off acutely, and this patient has suffered what we call an avulsion fracture. Now, the treatment for this condition is initially some non-weight bearing and then some guided physical therapy to gradually return back to sport. The vast majority of these patients are able to get back to full sports participation without pain over the course of about 2 to 3 months. However, there is a little bit of controversy on exactly what it is that increases the risk of this injury the most. It's probably an interplay between significant amounts of volume in sport, so just simply playing too much and early sports specialization. But as patients are growing, particularly adolescent patients who are growing considerably between the ages of 11 to 15 during rapid periods of growth for both boys and girls, that considerable rapid growth leads to significant tightening of various muscles across the pelvis and the core. And during that process, when they're growing, if they're playing a lot of sports, most of the trauma of overuse is going to be passed on from the muscle and the tendon into the growth center or the apophysis. Next slide. So if we know that they're considerably tight during the periods of rapid growth and they're involved in a lot of sports, and the interplay of these two things is putting a lot of pressure on the growth plate, really the only thing we have over control over this entire process is to elongate the muscles as much as we can through dedicated strengthening and stretching and flexibility protocols. So I would say that the most important prevention for growth plate injuries associated with the pelvis and the core is to do whatever is possible to improve flexibility of the hamstrings, the quadriceps, and the hip internal and external rotators as much as possible during the process of training. Next slide. So we'll talk a little bit about exactly what it is to consider when we think about overuse injuries. And as I mentioned before in a previous slide, we call these tendonitis, apophysitis, and bone stress injuries or stress fractures. When these begin to happen, what you're really noticing is there's going to be pain in an affected area consistently after physical activity. If this specific type of injury is allowed to progress, then patients may say that before it used to hurt me after sport, now it's starting to bother me while I'm playing. That's stage 2. Stage 3 then is it becomes severe enough while they're playing such that they have to restrict themselves or they begin to biomechanically limp. And then stage 4 is that now, even after taking a day or two off, I'm still uncomfortable and I'm still in pain. The typical pattern of overuse injuries progresses throughout these stages, and treatment is designed at bringing you back upward through the stages. So reverse from 4 to 3 to 2 to 1. Next slide. Here is an example of a specific kind of overuse injury associated with growth plate irritation. So calcaneal apophysitis or Sever's disease is a traction apophysitis or irritation of the growth plate associated with the calcaneal bone or the heel. This is an overuse injury that most patients describe as heel pain that gets worse throughout the end of the day in association with activities. So this generally happens when it presents towards the end of activity, and it is an overuse injury. So if it goes unchecked, eventually patients may say it bothers them during, it causes a limp, and then it bothers them even at rest. Typically speaking, when you examine patients who have calcaneal apophysitis, you will notice that their ankle motion is restricted, so they have considerably tight calves. And on exam, when you squeeze the growth center distally to after where the Achilles tendon inserts, that's generally where they say they're having the most amount of pain. Next slide. So treatment and prevention for this problem is calf stretching. Improving flexibility of the calf complex, particularly the gastrocnemius muscle, is incredibly important to treat this problem and is the most effective for treatment and prevention. As patients are growing throughout the ages of about 6 to 12, that's generally the age range when we expect calcaneal apophysitis to affect children the most if they're active in sport. So to prevent it from happening, dedicated stretching protocols that improves the flexibility and motion of the ankle is incredibly important. And if done reliably, it can prevent calcaneal apophysitis from happening in the first place. And thankfully, if it does happen, it's not a serious issue. It doesn't have any long-term implications in terms of overall growth. And there is effective treatment. And conveniently enough, the treatment is the same as the prevention, which is, again, calf stretching. And in general, I advise my pediatric patients, if they're having very mild symptoms, that it's okay to play through it as long as they're stretching. However, if they develop significant enough discomfort that they're having to alter the way they're running or they're limping, then I recommend rest until that limp resolves. Next slide. Here's a clinical vignette of a 14-year-old male soccer player who's presenting with right knee pain and a painful bump in the knee. And he also reports that the shin guards he wears during soccer appears to bother him and rubs him on the bump. Next slide. This is a typical presentation we consider when we think about the diagnosis of Osgood-Schlatter or tibial tubercle apophysitis. Similar to calcaneal apophysitis, this is a traction irritation of the growth plate at the top of the shin bone, just underneath the knee. Typically, it happens between the ages of 12 to 15, and it's more common in patients who are playing multiple pivoting, cutting, running, and jumping sports, so soccer, volleyball, basketball, those types of sports. On exam, you may notice that there's a bump over the proximal aspect of the tibia, as diagrammed in the top left corner. And this area is usually quite sensitive to palpation. So generally speaking, when you touch this area, patients report that they have significant pain, and that's the area where they hurt when they're playing sports. Just like calcaneal apophysitis, you can track Osgood-Schlatter, generally speaking, to most athletes having it due to tight quadriceps and or tight hamstrings. Next slide. So, just like with calcaneal apophysitis, the prevention for Osgood-Schlatter is dedicated stretching of the quadriceps and hamstrings, and the treatment for Osgood-Schlatter is the same. Additionally, some athletes like to use this patellar tendon strap when they have this problem. This is a tool where the squeezing of this strap along the patellar tendon above the area of irritation takes some tension off that area and allows for some level of decreased pain associated with competition and games. I don't find that this considerably helps everybody, and so it doesn't have any harm associated with it. If athletes would like to try it, it would be perfectly fine. However, the most effective treatment is to improve the flexibility of the quadriceps and hamstrings so the tension on the tibial tubercle apophysis is decreased. Again, similar to calcaneal apophysitis, if patients are able to play without limping, then they're allowed to do so. But if there is any limping or biomechanical compromise, I generally recommend rest until that resolves. And if you have the classic history and physical exam for this condition, additional imaging is generally not necessary. Next slide. So here's another example, a 15-year-old female volleyball player who presents with bilateral knee pain, right worse than left. The pain is worse with stairs and after prolonged sitting, and worse with activity towards the middle and end of that activity. Next slide. This is a typical presentation of a condition known as patellofemoral pain. We consider this a problem that happens when there is some abnormal tracking of the kneecap along the trochlear groove. Some patients may describe what we call theater sign, which basically means that if they sit in an awkward position with the knee bent awkwardly for long periods of time, such as in a classroom or in a long car ride, that awkward position may lead to more discomfort and pain. And then specifically when they get up from that seated position, they'll describe considerable amounts of discomfort. Again, on exam, you'll notice some tight hamstrings. If you try to press the patella into the trochlea, that might reproduce pain. If you try to push along the medial and lateral patella facets, that might reproduce pain. And on exam, when you ask them to do a single leg squat, they may present with an exam finding known as dynamic valgus. Next slide. Here is an example of what dynamic valgus looks like. This individual on the leftmost panel is doing a single leg squat mechanics appropriately. And on the right panel, you can see that there's considerable dipping of that hip as well as abnormal medial motion of the knee towards the inside. This indicates that the hip abductors and external rotators of the hip are not adequately functioning strong enough, and increasing their activation and making them better engaged is going to be essential to correcting this and to prevent the kneecap from tracking inappropriately, to allow it to track more physiologically and to decrease the pain over time. This is also the prevention for this problem. So it's the treatment and the prevention for patellofemoral pain. Next slide. So we talked about the good, we talked about the bad, but we should also discuss the ugly. So particularly in female athletes, but in both athletes, men and women, they are more likely, female athletes are, to rupture their ACLs compared to their male counterparts. A multi-sport high school athlete may have up to a 10% increased risk of ACL rupture during high school and secondary sporting careers. And the cutting and pivoting sports generally are the ones that carry the highest risk of ACL rupture in our young athletes. Next slide. So is there anything we can do about that? Next slide. Well, there have been many things that have been trialed. There have been things like ACL braces that have been used at the NFL level and at the collegiate level. The studies consistently have found that they don't considerably seem to reduce the risk of ACL injury, and they also seem to get in the way of performance. They may have some roles in particular positions in American football or perhaps in downhill skiing, but across the board, across all athletes, they do not seem to be considerably effective in reducing the rate of ACL injury. Next slide. So what does work? Next slide. Well, what seems to work the most to prevent ACL ruptures are specific neuromuscular training programs that are similarly to how I discussed dynamic valgus, designed to better improve the engagement of the hip and the lower extremity in concert. So these neuromuscular training programs, if done under a qualified physical therapist and trainer, an athletic trainer, they allow athletes to learn safer movement patterns to reduce the risk when they're playing sport associated with landing from a jump and with pivoting activities. They're a combination of plyometrics and balance and flexibility and strengthening exercises. They have a positive effect on all athletes, but they have the biggest effect on risk reduction among teenage adolescents, females. Next slide. So here's some of the examples and pictures that these neuromuscular strengthening protocols may use, such as single leg hop tests to improve balance and teaching patients how to reliably land with a slightly flexed knee and to ensure that the center of mass is directly over the landing plate. Next slide. So does it really work? Well, we'll get into the data about that, but the likely answer to that question is yes. The nice thing about these prevention protocols for ACL rupture is that they're really easy to learn. They can be done at home with minimal to no equipment whatsoever. And there's now the protocols are sophisticated enough that people can follow along with them completely on their own. Next slide. Here's an example, the FIFA 11 Plus, of a specific protocol designed to be performed regularly to prevent injury associated with male and female athletes who are playing soccer. They consist of about 18 minutes total of various types of exercises that include a warm-up, a stretch, specific landing protocols, specific plyometric strengthening protocols, and then a cool down. They can be done basically with no equipment. They just need the ground and some space. And the instructions and pictograms on these slides are really quite easy to follow. Next slide. And does it work? The answer seems to be resoundingly yes. So this study was done in male soccer players, where it took several athletes and put them into a treatment arm and a control arm and asked them to perform the FIFA 11 plus injury prevention protocol. So specifically, a lower proportion of athletes in the intervention group experienced knee injuries on the whole. So 25% of the treatment arm had knee injuries compared to the control group, where 75% of them had knee injuries. And specifically, when it was stratified for ACL injuries, fewer ACL injuries occurred in the intervention group compared to the treatment group. Compared to the control group, accounting for basically a 4.25-fold reduction in the likelihood of incurring an ACL injury during the period by which this observation was performed. So dramatic increase in the risk of ACL rupture if athletes are able to follow this injury prevention program. Next slide. So a couple of pearls. There is no such thing as too much flexibility. There are some patients who are born with or develop considerable mobility of the joint, which is a somewhat different conversation. But when it comes to flexibility of muscles, especially during patients who are pediatric patients who are growing and developing, there really isn't anything as too much flexibility. And there's also no such thing as having too strong of a core or too strong of a posterior chain. Next slide. Soreness after activity should be gone within 24 hours of rest. So that's a pearl that's important to consider, because if patients are complaining about pain in the same area 24 hours after resting from some training or competition, that shouldn't be ignored. We should pay close attention to that. It's important to never play through biomechanical compromise or limping, and soreness in the same area should not be present for most days of a week. These are some just general area guidelines when it comes to overuse injuries and how to monitor them, and when it might be useful to seek the consultation of athletic trainers, physical therapists, and sports physicians. Next slide. And then on that note, I will segue over to Charlie.
All right, thank you. So these are the categories of topics I'll be going over, focusing specifically on youth resistance training. I mostly work with middle school and high school patients, so you all know that they keep us on our toes, so I need to be ready for anything. One of my patients recently told me their favorite exercise was a mix between a lunge and a crunch, and I gave them a confused look. and they said it's actually lunch. So I thought that was pretty good. I hope that this portion of today's talk will help you motivate your young patients on the benefits of resistance training, which has so much to offer mentally, physically, and even socially. We all know there's so many barriers to pediatric research. I don't expect to overwhelmingly convince you with studies that I've cherry-picked for this talk, but I did do a recent PubMed search for youth resistance training and negative effects with phrase searching, and 7 results showed up. Scanning through the articles, you'll actually find that they all talk about how resistance training, in fact, helped and not added to negative effects. Such things, mental fatigue, obesity, and abnormal blood pressure. So again, I think it's hard to find anything that's negative against youth resistance training. So let's start with some general myths. These are likely parental concerns that you might hear, and this is definitely not a comprehensive list. Probably the most common myth is that resistance training stunts the growth of kids, and parents are afraid of this. And really, we should be confident that resistance training and impact exercises do not negatively affect bone growth, and that it can actually be stimulating for bone mineral density. Height of children will be determined largely by mom and dad's genetics. Another common myth is that some may feel that resistance training is only helpful for certain sports, maybe ones that favor bigger sizes, such as football. But I would make a case that resistance training is just as important, and in some ways more important, to the general youth population. And I'll bring up some specific examples in just a few slides. Especially with females, there may be a stigma against resistance training because it will make you undesirably bulky. But in the youth population, most of the gains that happen, especially prior to puberty, will be neuromuscular adaptations. So this has more to do with the nervous system, its ability to recruit and coordinate muscle units, and not necessarily hypertrophy of muscle fibers. Some may feel like kids should wait until high school to start resistance training, but by that time, we've lost a large window of opportunity to reap the benefits of resistance training that can be really gained in elementary and middle school years. Overall, there's been an old school thought that kids get injured in the weight room. And I think that may be true when kids are not well supervised or instructed, but that can also be true anywhere, in the garage, in PE class, on the practice field, even on the playground. So we just need to make sure that someone qualified is helping them make good decisions. There's a strength coach that has often been quoted: if you think lifting weights is dangerous, try being weak. Being weak is dangerous. So one more slide regarding bone health, just to emphasize this point. This was a systematic review and subsequent position statement from 2019. This included articles specific to adolescents and peak bone mass related to exercise. 4 out of the 9 criteria that were used in selecting these articles specifically involve resistance training and impact exercises. So they concluded that vigorous physical activity, including resistance and impact, are effective in improving peak bone mass in adolescents, and that significant results were seen after 5 to 6 months of this type of training. So again, I think we should be confident that resistance training and impact can be helpful for overall bone health. We should be encouraging this type of training as a long-term program and not just periodic spurts here and there. It's been well documented that 95% of adult bone mass is achieved by the time you're 18 years old, and that a majority of the gains in bone mass happen in the middle school years. So whatever they can accumulate at these younger ages will help them later in life as they slow down and grow older. The category of patients who are athletes would seem to be an obvious choice when it comes to advocating for resistance training, but there are so many barriers with this group for different reasons. Some are so packed with year-round practices and tournaments that there's no free time or energy to squeeze it in during the week. Off seasons really don't exist because there's an expectation to always be playing your sport, and if not, you're with a private coach getting skill-specific repetitions to help secure your ranking or spot on the team. And then there are some groups of athletes, as well as parents and coaches, who are reluctant to include resistance training into their routine, especially when it comes to endurance type of sports. This could have been included on the list of myths that some athletes should not be involved in resistance training because it will hurt their performance in sports. So I included a few slides just to briefly touch on the athlete population. So this was a small study from the UK on high school distance runners. In addition to their normal running practices, they had a strength training group paired with a non-strength training control group. The strength training group performed weightlifting, jumping exercises 2 times a week for 10 weeks. And what they found was that the strength training group had a significant improvement in both maximal running speed and running economy compared to the control group. They also did not find any detrimental increase in body mass or decrease in aerobic fitness in the strength training group. If you ask any college distance runner or coach about resistance training, they are unanimously in the weight room year-round. Their exercises may look a little different than the football team, but nonetheless, they are utilizing resistance training to help keep their athletes competitive. This was a small study done on high school swimmers. Similar to the previous study, they had a resistance training group that performed upper body exercises in addition to their typical swim sets. The control group performed only their swim sets at practices, and the resistance training group performed exercises twice a week for 9 weeks. And they found some positive results with the resistance training group in both the 25-meter and 50-meter freestyle distances compared to the control group. Anecdotally, I recently had a patient who was a high school senior, will be swimming this upcoming year for our collegiate program, and he's not even a short distance specialist. But even before arriving for his first semester, he was given a very detailed resistance training program that he started at the gym, and this was to help optimize what he's doing in the pool. What about resistance training from an injury reduction standpoint? I know this was already touched on earlier this morning. I see about 11 patients in a full day. There have been days where 9 of them are post-op ACL reconstructions. So unfortunately, there is no shortage of knee injuries in the youth sports population. And this continues to be a growing problem in this day and age of advanced technology and information sharing. So I just want to share this systematic review and meta-analysis published earlier this year. They included 19 RCTs published in the last 25 years. So this included over 28,000 subjects. The injury risk reduction with resistance training is significant. So having athletes work on a combination of core, balance, total body, and neuromuscular exercises needs to be more than an option. It's not just for elite athletes or athletes that happen to have the free time. The greatest ability is availability, and that's a quote from a former NFL coach, and it really does highlight the importance of health and safety in youth sports. How can you compete to the best of your ability if you're injured or on the sidelines or having to go to physical therapy? So really, resistance training is a way to try and avoid having to see us healthcare practitioners, and that's really what we want for as many youth athletes as possible. Sometimes it's easy to forget about the benefits of resistance training for those who are not involved in sports. Depending on your patient population, this may be a majority of the young people that you see. So I'm hoping that something in this section hits home for you. You may have a patient who is larger than most of their classmates, the last one to cross the line during the timed mile in PE. But in the weight room or gym, they could be the top of their class and feel extremely positive about themselves because of this role reversal. Conversely, you may have the patient that's smallest in the class, probably with a birthday early in the calendar year, maybe the last one picked in PE for team sports. But they could be the one who can win a push-up contest or pull-up contest very easily compared to their peers. So resistance training can really be a way to help teach kids a lot of important skills, especially when it's in a small group environment. Discipline, trust, communication, pride, empowerment, teamwork, just to name a few. It doesn't require the time, energy, and effort, or really even the coordination and skill that typical sports require. So resistance training may be a great primary sport for youth who are not interested or not involved in organized sports. This was a systematic review published last year, looking at 29 RCTs involving overweight, and obese children and adolescents, and the effect of aerobic exercise combined with resistance training. More than 2,000 patients that also included a control group. And the conclusion was that a combination of both aerobic exercise and resistance training was found to be helpful in improving several different health markers. And these are most of what we'd want to see in a healthy young person. This is also likely the group of patient that isn't too fond of aerobic exercise. So being able to recommend resistance training as a component of their weekly routine might help with buy-in and patient motivation. Recent studies indicate that approximately 1 in 7 adolescents aged 10 to 19 globally suffers from mental health issues, with depression and anxiety being the most prevalent. The COVID-19 pandemic further exacerbated these issues, leading to increased mental health issues among young people. And I know I'm preaching to the choir here. So this was a review article published last year. It highlights the importance of physical activity and its psychological benefits. Over 61 articles were included in this review. And I just wanted to highlight their findings on strength training, which was specifically associated with a decrease in depressive symptoms and increase in self-efficacy. So we may not be able to change the trajectory of every child who ends up with mental health issues. I know that, but what if recommending resistance training at a young age could help just one of our patients, and we would all be willing proponents? This is a commentary published in 2023 by the ACSM. It features Avery Feigenbaum, who's an exercise physiologist, currently based in New Jersey. I consider him one of the most respected experts on youth resistance training, so I wanted to share some thoughts inspired by him. At its simplest form, youth resistance training is about youth physical literacy. Childhood and early adolescence is a critical window for developing physical literacy, just like it is for other types of literacy, whether it's language or math or social skills. But it can't be assumed that schools have the time and resources to teach kids movement, or that they will easily learn these skills on their own or through signing them up for sports. We've already highlighted the multiple benefits of resistance training, which I think is well depicted in this infographic. And this really covers a wide range of positive impacts for our patients, and really things that we'd want to see at an early age, regardless of the patient's interest in sports. The term resistance training refers to a wide range of loading, different movement patterns and speeds, various training modalities, weights, bands, machines, medicine balls, and even body weight exercises, which I would really emphasize for the younger age group. These should be taught ideally at a young age, and they'll evolve over time based on patients with different needs, goals, and abilities. And these can be thought of as a cornerstone to lifelong health and fitness. So practically, what should we look for or advise our patients and families to consider when thinking about resistance training components? This is a summary of recommendations I put together based on 2 articles published by the AAP. First one in 2008, and then it was updated in 2020. So encourage a proper warm-up and cool-down. I don't know if it's surprising to hear that youth organized sports are notoriously not good at this, but this is a primary way that we can also help reduce potential injury. Younger kids and those with little resistance training background should start with bodyweight movements until they demonstrate proper technique or form, and this may take a while. Then weight or resistance can gradually be added, and I think this is another important step in really helping to prevent injuries. Ideally, resistance training is not spread out randomly when time allows for it. Really, the benefits that have been brought up are most effective with a consistent effort, which should not be surprising. Anything is probably better than nothing, but if exercise truly is the best medicine, then we want our youth to prioritize it in their life, and that also needs to be facilitated by their parents. Supervision is critical, but I know it's often a challenge to navigate. Young patients who are referred to us for physical therapy will get this type of training. But what about when they're discharged? Or what about the general youth population who doesn't come in for PT? Finding a local pediatric strength coach or trainer is not easy, but there are many credible organizations that offer certifications as a youth fitness specialist. There are gyms and fitness facilities, both large and small, that have trainers who are more familiar with working with young clients. So seek them out locally where you are. And when you find someone good, make sure to include them in your network, just like any other specialist you would have in your contacts. These resistance training programs need to be tailored to the individual in order to maximize safety and effectiveness. And whenever possible, it should be kept fun and interesting, especially in the elementary and middle school years. Otherwise, you'll get plenty of eye rolls and feet dragging. I know you may not always get the opportunity to have lengthy conversations about the benefits of resistance training. This pyramid of athletic development is something I simplified from Al Vermeil, who is a Hall of Fame strength and conditioning coach. So I thought I could wrap up with my elevator pitch version. So strength is really the foundation of any form of movement. And so whether it's someone looking to get recruited to play college sports or just make it through PE class, strength is really the building block for success. The bigger and broader the strength base of the pyramid, the better the body is built for basic lifelong functioning. And for those who are interested in sports, the bigger and broader the base of the pyramid, the more they can develop the qualities at the top of the pyramid. And so I really hope that we can consider effective ways that we can prescribe or advocate for resistance training or base of the pyramid building to a broader scope of patients and families that we're caring for. And thank you for your time.
Great. Thank you so much, Dr. Balaji and Charlie. Now we have a few moments to answer some questions. I'll read off a few that we have here, starting with, do you all have a plan or resource for strength training and or stretching that our attendees can provide to their athletes, their youths that they see? What age is the best time to start doing these strength trainings and stretching routines?
I'll take the when is the best time to start question. I think it definitely depends on the patient that's in front of you. Maybe a few things to think about are when they're signed up for organized sports, hopefully that means they're at an age and maturity level where they're able to follow instructions. And I think that's the best time to start. And again, strength training or resistance training can really be body weight. So at that young age, whether they're 6, 8, 9 years old, the earlier the better. And really it depends on how mature the young patient is. Can they follow directions? Can they do things safely? And I would say that's probably the best time to start.
Just to add on to what Charlie said, which I agree with wholeheartedly, from a strengthening protocol standpoint, I would say that in the ages that Charlie was mentioning, between the ages of 6, 7, 8, 9, 10, 11, those ages for both boys and girls, typically speaking, they haven't reached their early pubertal stages yet when they're at those ages. And so they haven't yet endured the significant increase in growth and the associated changes in their hormonal milieu. And so strength training protocols are very important and effective in that time frame, but you may not notice considerable changes in muscular size or muscular hypertrophy when they're doing those strength training protocols at that age. So between 6 to 11, 6 to 12, you may notice that they're getting stronger in the sense that they can do push weights more effectively. They may be able to do more reps with improved form, but most of those adaptations are neuromuscular, and they're improving their coordination, which is incredibly important for sport. After they enter the pubertal stages and they experience that change in hormones, that's when the signaling is available for them to start really putting on more muscle mass, particularly in boys, but this is true for both boys and girls. And so the hypertrophy changes will be noticed after the early stages of puberty have begun. And so it's important to developmentally understand that significant amounts of weight in terms of reducing the number of reps and improving and increasing the number of weights and doing that for the purposes of increasing muscle size is going to be very difficult to accomplish because children before puberty are not in a hormonal situation where that's really going to work. During that time, as Charlie mentioned, body weight exercises or doing things such as like squatting with a broomstick to get good form, those are effective ways of improving neuromuscular adaptation and getting strength that you may not be able to see visually. But after they've started to grow up and become more into the mid-adolescence ages, then the changes associated with increasing the weight visually will be able to be noticed as the hypertrophy signaling will be more effective. And then the next thing I would say is that it's never too early to start, really. And the sooner you start, the more effective it is. But it's important to create exercise and strengthening protocols that are age appropriate, developmentally appropriate, and sport specific. And so it's kind of difficult for us to give a one size fits all answer to that question because a 7-year-old swimmer is going to require a different sort of protocol strengthening. In that individual, we may talk about hip strength, core strength, and shoulder motion and shoulder strength. That's going to look a little different than, say, a lacrosse player at 11. And so there's going to be a different sort of approach to each one of those children, but the principles that Charlie mentioned are incredibly important.
Perfect. Thank you so much. We have one more question. Was there a point in time in the past when the recommended treatment for Osgood-Schlatter's was complete rest? If so, when did that change? Was there a difference in recommendation between sports medicine docs and GPs?
Yeah, it's a good question. I would say that textbooks published even until now probably just recommend conservative management in the form of rest for treatment of apophysitis like Osgood-Schlatter and Sever's disease. And the truth is, like, that works. Those recommendations were more effective in the past because we didn't live in a society where youth sports was as competitive and as all-encompassing as it is now. In the late 90s and early 2000s, yes, there was competitive youth sports, but the level of participation has ramped up considerably in the last 2 decades. And so there's been associated with that, there's been somewhat of a societal pressure to miss as little time as possible and keep athletes on the field. And for conditions like apophysites, as we understand them, there doesn't seem to be some price to pay later on. Although this is a growth center, it isn't responsible for linear growth. And if allowed to go through the growth process, these areas still seem to ossify relatively normally, even despite the fact that they become irritated. And so, given that there's been this pressure to keep athletes playing, and the fact that we've been able to manufacture ways to do that with some pain but no considerable long-term effects, the transitioning of the advice has been to shy away from dedicated rest and work towards ways where people can keep competing at a safe level, which is primarily to avoid biomechanical changes and to avoid limping. And so there has been a change. I would say that sports medicine physicians have been on the forefront of that, but there has been a change over the last 20 years or so in how we think about these problems.
Thank you so much again. Um, we have a few extra minutes if anyone else has some questions that they would like to ask our presenters. As a reminder, the recording for this session will be available in a couple weeks or so. Oh, we do have one. Do you have any thoughts on supplements for younger patients?
Yes, I can answer that. Supplements are what the word describes, supplements. So they are useful in very niche scenarios, but they are meant to augment a healthy diet that already consists of most of the essential minerals and vitamins that most people, including athletes, need. The science suggests that the various degrees of supplements that are utilized in the United States are generally not going to be useful if you're already able to get enough quantities of them in the diet. So if you have a robust diet where you don't have any absorption issues in the gut, you have healthy kidneys and you have a healthy liver, and you're able to absorb all the nutrients that you're eating in your diet, as long as you have a foundationally well-defined diet with adequate calories and an appropriate amount of macronutrients in protein, fat, and carbohydrates, you don't really need additional supplementation. In terms of what additional supplementation does have some science behind it, in general, our population tends to have decreased amounts of vitamin D because we spend a lot of time indoors and we don't get enough sun exposure. And so, a lot of patients, athletes included, may suffer from vitamin D deficiency and some associated complications associated with that. And so vitamin D supplementation could be useful because it's hard to get enough of it in the diet if you're not getting enough sun exposure. So that's one. The second thing I would say is that things like protein shakes are generally useful in the sense of being able to fill in the gaps of when you're not able to get enough protein in your diet. I would recommend that everybody carefully check through where they're getting their protein sources from if they're going to use shakes and they're going to use powdered protein because those are not generally subjugated to regulatory boards. And so a lot of advertisers are allowed to say whatever they want in terms of what they think is in their product, even if they haven't been proven to have that in their product. So the National Science Foundation and the National Sports Federations have put their stamp of approval on a handful of products that they've independently tested, and I would recommend veering towards those products because they've been shown to actually contain the protein content that they advertise. And then the other two supplements that many people discuss are things like creatine and caffeine. Consistently, it seems that throughout various journals that have published on creatine in the last 20 to 30 years, it seems to be a safe way of obtaining a way of generating some short-term bursts in strength. It also more recently seems to have some growing evidence that suggests it may have some cognitive benefits as well. I don't have a blanket statement on how old or young it would be safe to start creatine. In general, I say the studies have been tested at the youngest in terms of late adolescence, so 16, 17, and 18. It seems to be perfectly safe. It's probably safe even younger than that. It just hasn't been tested and verified yet. And so I think creatine is a safe supplement, although it's not quintessential or absolutely necessary for every athlete. And I would also say that small volume caffeine, if you are okay with drinking black coffee or healthy sources of caffeine, are useful about an hour before competition because it does have an ergogenic benefit. So about 50 to 60 milligrams of caffeine in adolescents, approximately an hour before sport or competition, can boost performance ever so slightly. Again, not absolutely required.
Great, awesome. We do have a few questions also regarding um, using weights versus using body weight for young athletes and again, like a general age breakdown of when you feel these might be appropriate.
Charlie, you want to take that one?
Sure. I would say it also depends quite a bit on the patient in front of you. We know that, not all 10 to 12-year-olds will look the same or be able to comprehend things the same or even have the same body awareness. So really it's looking at how they move, emphasizing technique in the beginning. Once they demonstrate proper technique and things become easy for them, then at that point, it would be appropriate to start adding resistance, whether it's light resistance in any type of form, just so that it's challenging for the individual. But obviously technique and form, proper form is really what's primarily important for that young person. So it's hard to say at this age, that's when they're ready to actually start weightlifting. So I've had, 9-year-olds that demonstrate really good form, maybe better than a lot of the high school patients that I had, and vice versa. So it really has to be individualized, I think, and supervised appropriately.
Thank you so much. We have a question about strength training in youth athletes leading to increased peak bone density. Could you expand upon this point and estimate at what age bone density gains may taper off? There was also maybe some questions on stress fracture management. Maybe these could be touched on too.
Yeah, I could talk about stress fracture management as I mentioned that. So stress fracture management is somewhat complicated because various bones that become injured in the context of sport and participation due to bone stress injuries are treated differently. There's considered lower risk stress fractures. So some of the lower risk ones would be like the fibula. And then there's other bones that are considered higher risk for stress fractures. And those would be the anterior tibial cortex and the navicular and the base of the fifth metatarsal. The reason that these are different is because depending on where the lower extremity of the stress fracture happens, if in general this is an area that historically heals well, it's considered lower risk. And conversely, if this is an area that generally has been known not to heal well, it's considered high risk. And so The treatment of stress fractures, from principle standpoint, is to remove the patient from training and participation until the bone has become completely pain-free, and then work them back into their sport very slowly under the supervision of an athletic trainer or physical therapist to make sure that biomechanical changes that contributed to the stress fracture are addressed and to make sure that their volume doesn't become too high. So in a point blank, that can take about 2 to 3 months to recover adequately. However, I generally lean towards more conservative and keeping people away from sport longer if they have what I consider to be a higher risk. So femoral neck stress fracture, anterior tibial cortex stress fracture, or navicular or basic fifth metatarsal. If it's one of these higher risk and we know that those don't heal quite as well, I usually keep them non-weight bearing and I keep them away from their sport for longer, 6, 8 weeks, before I start having them work with a physical therapist or athletic trainer to ramp back up. And then I advise that physical therapist or athletic trainer to go as slow as possible to ensure that the injury doesn't recur or it happened in another spot. So principles are rest, rehab, but the severity or the conservative or liberal nature with which I use those protocols vary depending on where the injury is.